we know that there's ongoing adjuvant studies, EMERALD-2 with durvalumab and bevacizumab, a very similar trial design, single agent IO with Pembro and Nivo. And, given that IMbrave050 turned out to be negative, just in the closing, sitting here today, what would you do different if you were launching the study next week?
Yeah, that's it. It's always hindsight is 2020, and we've had a lot of postmortems as a steering committee about the trial. The reality is the other three trials of the Checkmate 9DX, the Emerald-2, and the Keynote 937 are probably all going to be negative trials. And I think we can safely say it'd be surprising if either one of those three were positive, because in the IMbrave050, it was actually a higher risk patient population than the other three trials. We allowed macrovascular invasion, whereas the other trials did not allow that. And it really, what we would have done differently is probably really hone in on this idea of high risk of recurrence. I think a little bit of it was, this was really one of the first larger trials, other than the old sorafenib adjuvant trial, in the adjuvant setting, and very few actually have been able to define what is high risk of recurrence. Even though we chose the parameters for high risk of recurrence, the reality is most of the patients that were on trial were solitary tumors greater than 5 centimeters in size. And you can actually argue, is that really a high-risk patient population? And should we actually have been more, kind of included more of the macrovascular invasion, the VP1 and VP2, which when you look at it was only a very small amount of patients. It was 7% in the atezolizumab bevacizumab arm and 5% in the active surveillance arm. So a very small percent. So you could argue this wasn't really truly a high-risk patient population. And I think in future trials, it's really trying to figure out what that definition is. And I think all the other trials are probably going to be negative until we can kind of hone in on that.
Well, interesting thoughts. Unfortunately, like you said, the results were not maintained, but maybe there is a signal there, and we'll have to see where the field goes next. I think there's a lot of interest in neoadjuvant therapy now, based on what we learned from melanoma with Ipi-Nivo and, sensitizing the immune system when the tumor is still there. But thanks for taking the time today, Adam, and thank you all for joining us on this GI Oncology Now on adjuvant treatment for liver cancer in the IMbrave050 study. Thank you.
Thanks for having me.